Good afternoon. Wow, just last year we were able to host our Aging at Altitude Expo and Speaker Series at the Jewish Community Center in Boulder. Well, the times they certainly are changing. This year we're hosting our very first virtual expo and webinar series. My name is Mansi. I'm the president and CEO for Prairie Mountain Media, publisher of the camera, and moderator for today's session. First, let me welcome everyone to today's webinar entitled Eye Health, Age-Related Macular Degeneration, Cataracts and Glaucoma. So before we get started, please take a look at the bottom of your device screen. There you'll see a Q&A box or a chat box. Please feel free to enter your questions during the presentation, and they'll get accumulated and we'll ask them. Today's speakers will present for about 40 minutes, so we'll have about 20 minutes afterwards to answer your specific questions. I also like to remind everyone that if you would please visit dailycamera.com/aging, you can go to our virtual expo and support our partners. Now let's get started. First up will be Dr. Matthew Manry. He's from the Eye Care Clinic of Northern Colorado. Next, we will hear from Dr. Mansi, Parikh. So please join me in welcoming Dr. Matthew Manry to start us off today.
Thanks, everyone. Thanks, Matt, for having me. It's an honor to kind of kick this webinar session off. If I just do a second to share my slides here. I'm guessing everything looks well set up for this. So as Matt said, I'm one of the physicians at the Eye Care Center of Northern Colorado. And what I'm going to be talking about today is macular degeneration, kind of have it split up into 2 seconds. Dr. Parikh will be covering cataracts and glaucoma. We'll talk a little bit about how the eye works in general, just a brief overview. What is macular degeneration? How is it potentially treated? And leave plenty of time to ask any viewers questions. So like I said before, I'm Dr. Matthew Manry. I'm a board certified ophthalmologist and retina specialist, both medical and surgical treatments of retina disorders. Joined the Eye Care Center back in September of 2018. So I've been here just a little shy of 2 years. After being raised in Florida, I did my training at the medical school at the University of South Florida, residency training in ophthalmology at the University of Michigan, and then surgical retina training fellowship at the Cincinnati Eye Institute and University of Cincinnati. Our practice is one of the largest and the area's leading comprehensive eye care group, treating a variety of different eye diseases. Our main office, as you can see pictured here, is in Longmont, but we also have offices in Boulder, Lafayette. We can be reached via the phone number here and also on our website to schedule appointments. Also, very recently, we opened our own surgery center that's on site in Longmont. It exclusively treats eye diseases and has eye surgeries here. So that if we need to do cataract surgery, retina surgery, or other issues, we can try to keep it right here in Longmont. A brief overview of how the eye works. As you can see here, light enters through the front part of the eye. The cornea is kind of the window to the eye, a clear window that helps begin the focusing of light. The pupil is the colored part of the eye, typically brown, green, or blue for most individuals. And the lens also helps drive that light source and the image into focus. As Dr. Parikh will go into later, the lens is the part of the eye that over time will develop a cataract and kind of cloud over, which can sometimes blur vision. Light is then focused onto the retina, which is a light sensing tissue in the very back of the eye. And then that signal is sent to the brain via the optic nerve. If we think about the eye as a camera, the cornea is kind of the clear window in front of the lens. The lens helps focus things. The retina is like the film of the camera. And then the optic nerve is the cable that would take your camera and connect that to the computer to send the signal. The retina, as we see here in this image, the light sensing signal, I don't know if you can see my mouse, but right here in this image, this is the optic nerve. The blood vessels, the smaller blood vessels here are the arteries. and then the larger blood vessels are the veins that are taking blood back out of the eye. When it comes to the retina, the majority of vision is done by the macula, which you can see right here in the center, and specifically the fovea in the very center gives us our nice, really crisp, clear vision of what we're trying to look at. So today we'll be talking a lot about macular degeneration. Well, what is macular degeneration? It's one of the leading causes of severe vision loss in our more elderly individuals, typically starting around age 65. It's an abnormal part of the eye aging process and typically will involve both eyes, although can be somewhat asymmetric, meaning involving one eye more than the other. At least early on, people don't always necessarily have symptoms, routine eye exams can help pick up some of the earlier changes. As we look over time, the prevalence in society is fairly low, about 1 to 2, maybe 3%. Starting around age 65, and as we get older, that increases during time. So individuals age 75 or older have a much higher prevalence of the disease. You can see here how normal vision, you can see things pretty clearly, and in macular degeneration, the very center of what you're trying to look at may be blurry or sometimes completely missing. When we look at people who are potentially going to develop risk factors, older age is one of those larger risk factors. Family history is pretty important as well, and sometimes there's different genetic components and different genes that can make people more prone to developing macular degeneration. Those can be things like our complement factor and other genes that impact this. Cigarette smoking and tobacco use is also a really large risk factor and one that's a really modifiable risk factor. We find that people who are actively smoking have a much higher risk of developing more advanced macular degeneration and going from what we call the dry to the wet form. Those who have a previous smoking history but have quit smoking have still a potentially elevated risk but is lower. Also, we'll talk a little bit about the dietary components and how that factors in. Other things that we see as possible risk factors, but maybe not as sure as female sex, a lightly colored iris, like a blue iris, a history of cardiovascular disease, high cholesterol, high blood pressure, being overweight and obesity may be a risk factor, as well as a lot of bright sun exposure. When we look at macular degeneration, people will wonder, is cataracts or having cataract surgery a risk factor? And not that we can see. So it is generally safe to have cataract surgery. And in fact, a lot of patients with macular degeneration will find that they do benefit from cataract surgery as they get more light into the eye and try to make the most of the vision that they have. Typically, symptoms will be, like we said, blurriness or having a hard time looking at what you're trying to identify. So that may be difficulty reading or sometimes recognizing faces. You'll typically have distortion in your vision. So something that you'll want to look at will have parts that are distorted or appear absent. We'll talk about this a little bit more in a few minutes, but this is a sample of an Amsler grid, which is kind of a standardized way to look at your vision. Typically, all the lines are straight and evenly spaced. People with macular degeneration or other macular or foveal diseases will see some distortion in that grid. So when you're coming in for an office visit or having an eye exam that may screen for macular degeneration, beyond just looking at the eye, which will give us a lot of information, sometimes your eye doctor will do special photos of the eye or an OCT, which is an image that gives you kind of a cross-sectional view of the retina. You can see here these deposits beneath the retina that we call drusen. And those are analogous to these kind of whitish, more kind of yellow, creamy spots that we see within the retina. An angiogram or a fluorescein angiogram is a procedure where we'll inject a vegetable-based dye through a vein, typically in the arm. That allows us to watch blood flow through the eye. And in patients with macular degeneration or other retina diseases, that can help us diagnose the underlying problem and best figure out the way to treat that problem. As we look at the macular degeneration, there's kind of two different subtypes that will generally classify macular degeneration. The first is what we call dry or atrophic macular degeneration, and the second is usually referred to as wet macular degeneration, but you may also hear the terms exudative or neovascular macular degeneration. Dry macular degeneration is by far the most common form. It's about 90 to 95% of the type of macular degeneration that people have. Vision loss is typically very gradual with time. So starting out asymptomatic, and then typically over the course of many years, people will notice a progression of the macular degeneration. Dry macular degeneration is typically hallmarked by what we call drusen. Now, as people generally age, they can form these deposits beneath the retina called drusen, and those deposits are a byproduct of kind of the light sensing cycles of the eye over time. But if enough of these drusen deposits start to accumulate with a large enough size and configuration, then we consider these to be a little bit different and atypical, and that's the usual diagnosis of dry macular degeneration. Over time, this may also develop areas of atrophy where the retina dies off and is no longer functioning, and that's called more atrophic or geographic atrophy. Early on, it may be just a few drusen, and your eye doctor could classify this as more kind of intermediate or late stage. We can see some examples here in images C and D right here, where those patches of atrophy are starting to form. And here is another example of this atrophic macular degeneration. Areas of pigment are missing, and you can see some blood vessels beneath in the layer that we call the choriocapillaris. Well, when we're looking at the macular degeneration, what are some things that we can do to try to prevent this from getting worse? The main thing, or one of the main things that we've looked at, is vitamin supplements. So nutrition and dietary intake does play a role. AREDS2, which stands for the Age-Related Eye Disease Study. 2 means that it was the second time that this study was done, where they did tweak the formula some. That's been shown to reduce the rate of macular degeneration progression and reduce the possibility of dry macular degeneration switching to the form that we call wet macular degeneration. As you can see here, vitamins C and E are used, as well as minerals zinc and copper. And then some antioxidants, lutein and zeaxanthin being the main antioxidants that were studied. There are some other antioxidants that you'll find in other compounds as well that we'll talk about, but the main one is anything that says AREDS2 on it. Also helpful is a multivitamin. So when this was studied in the AREDS2 study, in addition to this special formulation here, patients were also on a multivitamin, and so that is recommended. You can see here other brands that you might find out there in the community. And they may contain other supplements and other compounds, which are generally going to be considered safe to take. But the main thing would be wanting to see the amount of, like I talked about, kind of vitamins C and E, lutein, zeaxanthin, and those other components. When we look at diets, studies also show that a good, healthy diet of antioxidants, green leafy vegetables are helpful. The Mediterranean diet, so a lot of kind of fish, olive oil, beans, things like that, also does reduce the rate of macular degeneration progression. Tobacco products are a big factor in this, though, and tobacco products are one of those main risk factors that I really recommend if you're actively using tobacco, and especially if you have active macular degeneration. That's kind of number 1, 2, and 3 on the list of things that you can do to try to reduce the risk of a poor visual outcome. As I talked about before, an AMSR grid is kind of a standardized box that's used to monitor for macular degeneration. Typically, this test is done one eye at a time, looking at this kind of dot right here in the center and checking to see, do all the squares look like they are about the same size and shape. Here's an example again of an abnormal AMSR grid. Now, there are other eye diseases that can cause changes to an AMSR grid. So if you were to notice issues on an AMSR grid, it's something where you'd want to see your eye doctor for evaluation to figure out what's going on to cause that. A device that an eye doctor may recommend if you have been diagnosed with macular degeneration is a home monitoring test. This is the 4C home monitoring system, where it's a test that you would take typically most every day, looking for abnormal waves in what's typically a fairly straight line, and clicking on those areas that look abnormal. Depending on the results of this test that you take, you might get a notification that says, hey, we see some unusual things and you should probably go into your eye doctor for evaluation. This is a device that is sometimes covered by insurance, but not always. And so if you have an interest in it, then you generally want to talk to your eye doctor to see what the recommendations are and what insurance might help cover. When we look at people who have macular degeneration, they generally have perhaps the vision that they don't necessarily want to have. If the vision deteriorates enough, they may see a benefit to a low vision specialist, specially trained optometrists and occupational therapists that can help with low vision aids, visual rehabilitation, assistive and adaptive technology, and sometimes being able to come to your home and help with helping make your home work better for the vision that you do have. In terms of looking at future treatments for dry macular degeneration, there's a lot of drugs that we see in clinical trials that are currently being studied. There's not a lot of treatments that we have that are very effective besides the tobacco cessation and dietary and supplement treatments. We are looking at other treatments in the future, including things like stem cell transplants. But I urge a word of caution to anyone considering these. You want to make sure that they're part of a really well-designed clinical trial and recommended specifically by your eye doctor. You may remember a few years ago in the news, some stem cell transplant clinics that treated patients that developed a significant vision loss because of those treatments. So you want to make sure that if you're going to be involved in a study, it's been well vetted and recommended by your eye doctor. Now we'll move on to wet macular degeneration for a few minutes. That's caused by abnormal blood flow or abnormal blood vessels beneath the retina that can bleed and leak fluid into the retina. It's typically going to cause a much more rapid vision decline, sometimes over the course of several months. If it happens in one eye, can also likely potentially happen in the other eye. As you can see here on an image called an OCT, we see this abnormal blood vessel net with an area of fluid to the side of this abnormal blood vessel net. This is a comparative normal photo of a normal eye on the other side. Well, how do we treat this wet macular degeneration? Years ago, we used to treat it with a thermal laser treatment, basically kind of burning the abnormal area in order to try to keep it from progressing. It worked fairly well, although it would initially cause a drop in vision. So we don't typically use that much anymore, if ever. The standard of treatment is typically a medication that's delivered directly in the eye itself, which I promise sounds scarier than it actually really is. This is a drug that takes that abnormal blood vessel net and tries to get it to shrivel up and stop leaking. There are 4 treatments that are typically out there on the market for injections and have a pretty good chance of maintaining someone's vision or at least initially improving someone's vision right after diagnosis. A special light treatment called photodynamic therapy will also sometimes be used in addition to injections in order to try to get the macular degeneration under control. Surgery is used in various forms, but fairly uncommonly. You know, we used to look at surgeries to remove that abnormal blood vessel net beneath the retina, which in clinical trials didn't really make much improvement. In the time of cataract surgery, sometimes a special miniature telescope would be implanted in the eye to help kind of maximize vision and allow someone to see better. Generally, it would help some patients, but other patients found that a little hard to cope with, and so is fairly uncommonly used. And if the macular degeneration lesion causes a really large area of bleeding, then sometimes surgery is done to try to displace the blood and improve the vision. Questions that you'll typically want to have or ask your eye doctor is which medication is started. That's going to typically be a conversation between you and your retina specialist or ophthalmologist on which medication might be the best treatment for each situation. There's certain drawbacks and benefits to each. Typically, when someone needs to start injections, they will maintain those injections or need to be on those injections for the rest of their life. However, individuals will sometimes be able to get off treatment if we can get it under adequate control. Injections for a lot of people, at least initially, are going to be about a month apart. And depending on your treatment response, your retina specialist will usually tailor treatment specifically to your case. And in a lot of cases, be able to space those out so that the injections are not done or injections are done not nearly as often. Numbing treatments are done for the injections so that typically you'll feel little to nothing, maybe a little bit of pinch or pressure at the time of treatment when the medication is administered. Looking at other future treatments, oral medications and eye drops are something that have been studied in clinical trials and are continuing to be studied, as are ongoing injections in the eyes. The goal with a lot of these injections are either to get a better response to keep things under control so that you don't need treatment as often. Instead of maybe every month or two, these are injections where it could be, say, every 3 or perhaps even 4 months for an injection. Some of these are anti-VEGF plus another agent that are combined together. And there's one very promising one, which will potentially have FDA approval later this year, where injections are, for the most part, going to be about every 8 to 12 weeks apart, depending on treatment response. You can see here a port delivery system, which is a surgically implanted device into the wall of the eye. It has a reservoir here that's filled up with one of the medications that slowly disperses over the course of several months. When we see that the medication implant is running out, that can be very easily refilled just in the clinic. In clinical trials, patients were able to sometimes go 6 to 12 months or even longer between refills of the implant. And finally, looking at other treatments in the future, gene therapy. So having a safely designed kind of virus vector that would deliver a gene to the eye that allows the eye itself and some of the support cells of the retina to produce that medication on its own. So after treatment, the eye can make the medication itself that's needed to keep the macular degeneration under control. So in kind of conclusion, talking about macular degeneration, a lot of different kind of hopeful and promising treatments that are out there. If you have personal concerns of macular degeneration, either by family history or any vision changes that you're noted, it's recommended to have kind of a routine screening exam with your eye doctor to have more of a discussion of, do you have any abnormalities and where to go from there. That'll conclude my part of the presentation.
Dr. Parikh.
All right. Well, welcome everybody, and for everyone who's sticking around for the second part, which is my part. I'm just going to pull up my presentation here. So I'm going to be talking about cataracts and glaucoma. And just like Dr. Manry, I am over at the Eye Care Center of Northern Colorado, and he mentioned we have several locations. Our main location is up in Longmont. And I am a board certified ophthalmologist and a fellowship trained glaucoma specialist. I've been in practice since 2009. And I've just been here in Colorado since last year. I've moved around a bit and settled here. I'm very excited to be with the group here. I have 2 other partners here who are glaucoma specialists, as well as we have 5 cataract surgeons in our group. So just like Dr. Manry had already mentioned, he talked a little bit about the visual pathway. Just a quick recap. As he mentioned, light is focused through the cornea and the lens onto the retina. And the retina sends an electric signal through the optic nerve to the brain, and the visual centers in the brain are really where a picture is made. So if you look at this pathway, really disease in any part of this pathway can cause vision loss. One of the first places light is focused is through that lens, which you see in the front of the eye. And so we'll start there, talking about that. So just a general statement about cataracts and glaucoma. They are very common causes of visual impairment. Worldwide, cataract is the leading cause of reversible blindness in the world. So luckily in this country, many people have access to eye care and they don't go blind from cataracts. But in many third world countries where access is poor, people can go bilaterally blind from cataracts. The great thing about cataracts is that they generally can be removed and vision can be rehabilitated. Glaucoma, on the other hand, is the leading cause of irreversible blindness in the world. So we're going to talk about both of these conditions separately. So first, we'll just start with some basic information about what is a cataract. So like I showed in the initial slide, there is a natural lens in the eye. It sits behind your pupil. So in this picture, you can see that this patient has both dilated pupils in both eyes. And on the left side, you see this white cloudy lens, and that is a cataract. Now, cataracts don't always turn white, but it's just easier to illustrate with this picture. They often start by turning a little bit yellow, and eventually they can become brown or in some situations white. And the general symptoms that you see from cataracts are a slow, progressive blurriness to the vision. Typically, age-related cataracts do develop quite slowly, so sometimes people are not aware of the progression over time. The things that are really symptomatic are things like glare and halos. So often we'll hear people say that they have trouble driving at night. Headlights have quite a bit of glare. But in certain types of cataracts, you don't get as much glare. And in those situations, you get a slow blurriness and an eventual dimming of the vision. So here in this picture on the left side, you see not only is it blurry, but if you look at the area which represents the sky, instead of looking like a bright blue or white blue, you're seeing this yellowish tinge, and that can happen as cataract develops. And thankfully, like I had mentioned before, cataracts are reversible, and modern cataract surgery is quite fast and safe. In cataract surgery, the cloudy lens is surgically removed and replaced with an implant. So again, as I had mentioned earlier, the lens is part of the focusing apparatus in the eye. If we remove the lens and don't replace it with something, there will be a lot of power that has been removed from the eye and light cannot focus. So we do have to place an implant in the eye. Modern cataract surgery is typically a 10 to 15 minute procedure, and it's done under a local anesthesia and has a very low complication rate. The recovery is generally quite quick. Many people will see better the day after cataract surgery, but generally within a week after cataract surgery, your vision will improve. Cataracts do not grow back once they're removed. So I mentioned that we place a lens implant in the eye, and this implant is meant to help focus the light into the eye. Everybody's eye has a different shape, and so we do a bunch of tests before cataract surgery to determine the shape of your eye, and we use formulas to determine what type of lens implant would be best in your eye. There are lots of different types of lens implants out there. There are implants that can correct astigmatism. There are multifocal implants that can help some people see near and far. There are pros and cons to all these types of implants, and all of this is discussed during the pre-surgical evaluation. Once a lens implant is placed in the eye, it generally doesn't need to be replaced. There may be rare situations where the lens implant dislocates. Usually that would take quite a serious injury for that to happen. But for most people, the lens will remain in the eye, does not need to be replaced down the line. There is a possibility of developing a little bit of a film behind a lens implant after surgery, which can easily be lasered away in the office. And once it is lasered away, it will not recur. So we're just going to switch gears and talk about glaucoma. And glaucoma is really a group of diseases that cause a degeneration of the optic nerve. So now we're going to the back of the eye, and that's where this disease really affects the eye. Glaucoma is a chronic and progressive disease. And again, you know, the optic nerve is really a cable. It collects all the information from your eye and sends that information back to the brain. So it's really a critical part of the visual pathway. Any type of disease of the optic nerve is termed an optic neuropathy, and glaucoma is the most common optic neuropathy. So when we see people for a full eye exam, often we will dilate the eye, and when we dilate the eye, look in the back of the eye, we can see the optic nerve. So what we see is the optic nerve head. That's the part of the nerve that's inside the eye. There is, of course, a length of nerve that's behind the eye that we can't see. This is a picture of a very healthy optic nerve. The optic nerve is made up of over 1 million fibers that all come from the retina, and they form a bundle at the optic nerve head. The fibers tend to run around the edge of the optic nerve. And so sometimes I tell people it looks kind of like a donut. There's a rim that's around the edge of the optic nerve. And in the center part of the optic nerve, there's an area where there are no fibers. And that area is called the cup. In glaucoma, what happens is the fibers that are running around the edge of the optic nerve become sick, they become damaged, and eventually they die off. So as those fibers die off, the rim looks like it gets thinner over time, and the cup looks like it's getting larger over time. And that process is called cupping. This change in the optic nerve is very characteristic of glaucoma. Often the superior, so the top, or the inferior, the bottom rim, are the ones that are affected first in glaucoma. And these patterns are things that we look at when we examine the optic nerve. There are very, very few other diseases that cause changes like this in the optic nerve. So often we can diagnose glaucoma on a dilated exam. One of the things that happens when the optic nerve is damaged is you can have some issues with your peripheral vision. Now, many people who have heard about glaucoma know that peripheral vision can be affected, and they have this sense that peripheral vision being affected means that they're going to get tunnel vision. And while eventually down the line that can happen, that is not what happens in the beginning. I mentioned the nerve has over 1 million fibers, and you don't need all of those fibers to have perfect peripheral vision. You can damage up to 30% of the nerve and still have perfectly normal peripheral vision. However, once you get past that point, if you look at the center screen here, you can develop some areas in your peripheral vision where you don't see well. So when you're looking at this test, there's a cross here, and this represents the center part of the vision. Lights are around the side, and wherever you see these dark areas, I hope you can see my pointer, are areas that a person's having difficulty seeing the light on a test. The far right picture is a representation of more advanced glaucoma, where you really have a lot of dark areas on the top and bottom half of the vision, with a center area that often will remain seeing until late in the disease. So who gets glaucoma? Technically, anyone can get glaucoma. Babies can be born with glaucoma, children can get glaucoma, young adults can get glaucoma. However, that being said, glaucoma is a disease that's more common with age. The risk factors for glaucoma, again, are older age. Most commonly in a Caucasian population, glaucoma develops over the age of 60. This does vary by race. So race is also a risk factor. African and Hispanic background is a risk factor for developing glaucoma. African Americans in particular often develop glaucoma at younger ages, so they may develop glaucoma in their 40s, and they have a more severe course of disease. Family history is also an important risk factor. Glaucoma is much more common if you have a sibling or a parent who has glaucoma. And so in those situations, if you do have someone in your family who has glaucoma, it is important that you get tested. And finally, one of the most important risk factors is high eye pressure. High eye pressure puts stress on the optic nerve and can lead to the damage of the optic nerve. I do want to make a small comment here. The most common thing that we see is elevated eye pressure in glaucoma. However, it is possible for a person to have high eye pressure and never develop damage to the optic nerve. And in that situation, we would not use the word glaucoma. And it is possible for a person who has, quote, normal eye pressure to develop glaucoma. So While we do look at the number, what we're trying to really figure out in glaucoma is how the pressure in your eye is individually affecting your optic nerve. So if you're sent in, or you come in and you want to have some tests done for glaucoma, a couple of things to expect when you come in for an evaluation. The first thing is that we will do a visual field test. I showed some test results earlier, but a visual field is basically done in a machine like this. You can see that you basically sit at a machine with your chin on a rest, and each eye is tested separately. You're asked to focus on a certain spot, and lights are flashed around the side, and you push a button when you see the light. And from that, we can determine if there are parts of the peripheral vision that are affected. This test typically takes 5 to 10 minutes per eye. Takes a little bit longer if you have damage, but if you have a totally normal visual field, it can take 4 to 5 minutes to do per eye. The other common test that we do is something called an OCT. This is a scan that allows us to measure the actual thickness of the optic nerve. And we use this very commonly to monitor people who either are suspicious for glaucoma or have known glaucoma. The OCT, again, measures the thickness of the optic nerve, and it compares that thickness to a database of normals. And statistically, it will tell us if your optic nerve is an average thickness or thinner than average. The important thing about this is that we can do this test periodically over time, and we can compare your own eye to itself and see if there is any progressive thinning occurring. And if there is, we have the opportunity to change our treatment to try to stop that progression of disease. Just briefly, I'm not going to talk in a lot of detail about treatment, but glaucoma treatment in general is based around lowering the eye pressure. Regardless of where your eye pressure is at the time of diagnosis, lowering the eye pressure has been shown to help stop, prevent, or slow down progression of the disease. In general, the eye makes fluid, and there's a drain in the eye where the fluid drains out. So the fluid is circulating constantly throughout the eye. And you can think about treatment as targeting 2 different places. We can either try to decrease the amount of fluid the eye is making or increase the amount of drainage in the eye. The most common treatment that we use initially is eye drops. Eye drops typically are going to reduce the amount of fluid your eye is making. And there are a lot of different eye drops out there. They're dosed differently, and they have different side effect profiles. And if you do need to be put on drops, all of these things will be discussed when the drops are started. There are laser treatments that can be done that can help improve the drainage out of the eye. This is a picture of someone with a lens on their eye having something called an SLT, which is a laser basically to the drain of the eye to try to open the drain up and allow more fluid to leave the eye. There are surgical treatments, and in surgical treatments, I'm just splitting up into 2 separate categories. One is this picture, which is showing something we refer to as MIGS. MIGS is minimally invasive glaucoma surgery. These are small implants that are placed in the drain of the eye that can help basically increase fluid drainage out of the eye. And these types of procedures are often done in combination with cataract surgery in people who have glaucoma. And then there are more invasive glaucoma surgeries. These are typically reserved for people who need very low eye pressures. Those people would be people with very advanced disease or people whose disease is progressing despite a relatively low eye pressure. And in these types of surgeries, essentially you're bypassing the natural drainage system and creating a new pathway for the fluid to drain. So just key points to know about glaucoma. There is unfortunately no cure for glaucoma. This is a chronic disease, and our goal is to manage the disease. The optic nerve is an extension of the brain, and damage to the optic nerve cannot be reversed. So always our goal is to prevent the damage. And basically is in many, many things, early diagnosis is really the key to having a good outcome in glaucoma. Thankfully, if the disease is found early and treated properly, most people will not go blind from glaucoma. So just a general takeaway point, there are multiple diseases that can cause problems with vision as as people age. Macular degeneration is one of them. Cataracts is a very common cause, and that can be fixed easily with surgery. But the thing to know is that all vision loss is not cataract. And because of that, it is really important to have routine eye exams so that if there's potentially something developing in the eye, it can be caught early and treated early to prevent problems down the line. And I'm happy to take any questions.
I will tell you, I've been involved in these for a long, long time. Those were two extremely well put together and thorough overviews of two very, very common ailments that people deal with. So we do have questions. I think you had already talked about this, but do you recommend someone with no macular degeneration take supplements, particularly if they have maybe a family history or there might be a smoker?
Great question. That's one I think that we get pretty often. You know, as part of the age-related eye disease study, one of the things that they really looked at was, well, when does people get a benefit from taking these supplements, and should everyone be taking them? You know, people who are a smoker or people who have a strong family history of macular degeneration. The original formulation of the AREDS contained a component called beta carotene, and that was found in the studies to actually increase the risk in people who were smoking of the possibility of developing lung cancer. So that was actually something that was looked at and then removed in the second iteration or second formulation of the AREDS, which is why it's now called AREDS 2. And so that makes it safer for people who are smoking to take that supplement. When we look at who really gets a benefit and a proven benefit from taking the AREDS 2 supplements, it's individuals who have what's called intermediate stage macular degeneration or worse. So people who have a family history or people who have some of the perhaps very small early changes of macular degeneration don't necessarily see a benefit over time. That being said, it's likely to cause any harm, and if someone feels like they want to take the supplement, it's generally going to be a safe thing to do, even before that intermediate stage development.
We just had a question about marijuana. Can either of you talk about whether marijuana has any impact on eye health?
So I'll just make a comment because marijuana is something that often is discussed in the setting of glaucoma. There is evidence that marijuana can cause a decrease in eye pressure, and that's something that has been talked about for a long time. Strictly speaking, I think we don't have enough information to recommend that as really a treatment. There are people who have some concerns that while it may lower the eye pressure, it may also affect blood pressure and perfusion, which in some ways could be harmful in glaucoma. We know that pressure does go down, but typically the pressure goes down for a short period of time. We have medications out there that can control eye pressure for a much longer period of time than marijuana. So, you know, I would say that most glaucoma specialists at this moment do not recommend marijuana as a treatment for glaucoma. And we'll see, we're learning new things all the time about it, and it certainly may change in the future, but at this point, it's not a recommended treatment.
And we had questions about eye pressure. Can you feel eye pressure in any way? Is there any symptom related to eye pressure that someone might see? And could you describe eye pressure a little better for the person that's asking this question?
Sure. I see a question about what does high eye pressure mean. So if you think of the eye, this is a very kind of rudimentary analogy, but if you think of the eye like a water balloon, you could overfill it and it can have a lot of fluid in it. And in that case, the balloon would be more tense. Similarly, the eye, when the pressure is high, is more tense. And or this is not something we see naturally, but if a person has a surgery and sometimes they have a lot of drainage coming out of the eye, the water balloon could be soft, a little bit less fluid in there. So similarly in the eye. There is a range of eye pressure. We measure it with these machines that basically touch the cornea, and if you think of the eye as like a sphere that has fluid in it, we have these machines that push on the front of the eye, and when it flattens the surface of the eye, the pressure that the machine is applying is equal to the pressure inside the eye. It's just a general statement. So we use these machines to measure pressure. Most people's eye pressure measures somewhere between 10 and 21 or 22. It's millimeters of water. So that's what we're using as a terminology here. So the one thing I don't like about people's, the idea that there's a normal range of eye pressure is that, you know, a pressure of 21 or 22 is not a problem for everybody. And when we talk about treatment for glaucoma, sometimes people will say, well, my pressure's 20, that means it's normal, so that should be good enough. But it's a lot more complicated than that. If you do have glaucoma or you're having an evaluation for glaucoma and you're working with a doctor, you really can talk to them more about individual goals. People's eyes are different, they respond to pressure differently, and different stages of disease require, in certain situations, more aggressive treatments and lower pressures.
And so you really can't tell individually.
Sorry. So eye pressure, you don't feel it unless it gets very high. So there is a point where people can feel it. You know, typically the pressure has to be over 40, which would be twice normal for there to be a sensation of feeling pressure in the eye. Oftentimes, pressure in the eye can be felt sometimes as sinus pressure. So sometimes people feel like they have a pressure around the eye or above the eye, and it's actually because of pressure inside the eye. If pressure gets above 50, it can actually cause pain. Pressure that high causes swelling in the cornea, which is painful. So there can be pain, there can be headache, but most people who develop glaucoma are going to have pressures that are going to range in general under 40 if they don't have an acute glaucoma. And in those situations, you generally don't feel the pressure.
We've got a question about early macular. Somebody has early macular and developed a cataract in the eye and is worried that if the cataract is removed, will it speed up the progression of the macular degeneration?
That's a really good question. And that is something that has been looked at. You know, what's the effect of having cataract surgery on macular degeneration, and can cataract surgery have a negative impact in terms of progression of the macular degeneration? And that's not actually really something that we'll typically see. So cataract surgery is not going to typically lead to a progression of the macular degeneration. It's a safe procedure to have done in someone with macular degeneration. You know, people with underlying issues in the retina, you know, may not notice as much improvement in the vision with cataract surgery. But typically, you know, when someone has a cataract that the eye doctor feels like is impairing the vision, then, you know, especially someone with macular degeneration who may have, you know, trying to maximize the vision that they have, you know, they'll potentially see a benefit by getting more light in the eye and less issues with, say, glare and kind of fuzziness in the vision.
We had a question. If somebody could just take this, what's the difference between an optician, an ophthalmologist, and an optometrist?
I think either one of us can answer. I'll jump to it first.
Yeah. So there are a lot of eye care professionals out there. Opticians generally are going to be people who work with glasses. They are specialists at designing glasses and measuring things and getting a good fit for glasses and proper lenses. Optometrists are trained eye care professionals. They're trained in medical management of eye diseases and also of refraction. So generally when people go in to have glasses, contact lenses, things like that. Their training is not quite as extensive as an ophthalmologist. So ophthalmologists are medical doctors. So we have all gone through medical school as well as training in ophthalmology. So we do have base medical knowledge from our training about other systemic diseases besides the eye. And we are trained surgeons. So of those groups of people, we are the only ones that perform surgery. And if
Thank you
Matt
so
has
much.
anything to add, go ahead.
Thank you so much. This question about, is glaucoma among non-white population genetic or environmental?
So that's a great question, and it's a question that we don't have great answers to. Meaning, I think it's in most cases a mix, and it's not so easy to separate those two things out. Definitely, there is a genetic component that is true in every population, non-white or white. If things run in the family, it certainly is something we see more often. But it's interesting. There have been twin studies done where you have identical twins and one develops glaucoma and the other doesn't. So it's not a purely genetic thing, but trying to really elucidate what the environmental factors are is hard. And so I don't think that we have really clear-cut answers to what environmental factors may contribute to glaucoma, but certainly there is variation within populations. And I do think that genetics plays a big role in the fact that certain populations have a higher rate of glaucoma than others.
Thank you. Most people have floaters in their eyes, and some people have them and they're very noticeable. Can you talk a little bit about floaters in the eyes, and should people be concerned about them, and are there any treatments available for them?
Sure, that's a great, really common complaint that I think we see a lot from patients that notice their floaters. People will describe floaters really differently. And as a general term, a floater is, the little kind of strings, little dots or circles that people will see in their vision. I saw a couple questions being asked. One question was, are floaters related to cataract surgery? Oh, I'm sorry, to macular degeneration? The answer is no. So generally what floaters are is in the kind of further back part of the eye, there's a larger fluid pocket called the vitreous humor. The vitreous is mostly water, but it also contains some other substances and a lot of collagen, which gives it a little bit of structure. As we age, or I like to say accumulate birthdays, the collagen within the eye will tend to kind of clump together and form these larger groupings, which will kind of cast a shadow and lead to floaters in the vision. On rare occasions, floaters can be due to other things within the eye. So in someone who perhaps has advanced diabetic eye disease, floaters can be due to sometimes some bleeding within the eye and inflammation within the eye. But I would say 95%, 98% of floaters in someone's eyes are going to be benign. They're harmless. They're just annoying. When it comes to treatments of these floaters, there's kind of two generally prescribed treatments that are done. One is a laser treatment to the eye. The other is a surgery to the eye. The laser treatment is a laser to try to work to break up those collagen clumps of the eye. It's something that's come up more recently in recent years as a treatment, but generally not one that I recommend. There's some studies that look at the efficacy of it, and it does potentially help, but can require a lot of treatments and may not overall improve the quality of someone's vision. And generally more definitive treatment is a surgery to the eye called a vitrectomy. And what a vitrectomy does is remove that vitreous humor of the eye. The vitreous doesn't serve a lot of purpose after someone's eye develops in the womb. And so that can generally be safely removed and getting rid of the floaters of the eye. If it's something that someone is interested in, I generally would advise talking to the regular eye doctor about that.
That was great explanation. Question about dry macular degeneration. Is UV light harmful? How about blue light from computer screens?
Another good question, another one that we really get. UV light and sunlight is something that is one of those potentially harmful. We don't know absolutely for sure that it's definitively harmful. So it is generally going to be recommended for overall eye health, say, the progression of cataracts and things like that, to have some sort of UV protection on. So UV blocking sunglasses and things like that are going to be recommended. When it comes to blue light specifically, blue light is not one of those generally well-known risk factors, and the evidence is still definitively out on blue light blocking and its harmful effect on the eye, but is unlikely to be the one that's very specifically harmful in macular degeneration.
We've got a couple of interesting questions here. Do air bubbles get injected with macular degeneration injections?
Yes, that is one of the things that, as a medication, as the injection goes in the eye, we try to do as best we can to get all of the air out of our syringe that we used and out of the needle. It's not always possible to get 100% of the air out, and so most of the time you won't have an air that goes in, but you will have air that does go in after an injection. Typically, we'll see it as patients will see it as a kind of a perfect circle in their vision that'll last for a day or two after the injections and then goes away. It's a harmless event associated with the injection, though, and it's not anything to worry about.
Question about AREDS 2. Somebody is taking AREDS, doesn't seem to be helping at all. Is there any danger to doubling the dose?
So it's that's a very good question. A lot of the AREDS 2 components are all going to be fairly safe to take. Most vitamins are going to be water soluble, meaning that you can take a lot of them and they don't really build up in the body. Vitamin E is one of the components of the AREDS 2 vitamin that is a fat soluble vitamin, meaning that you can kind of overdo it with vitamin E supplementation. Now, it usually takes a lot to overdo it or overdose on vitamin E. But generally, if people are not seeing an effect or an improvement with the eye vitamins, that's not generally a bad thing. The goal of the eye vitamins is trying to prevent worsening. And so by taking these eye vitamins, you're not going to see an improvement in your vision. It's just trying to slow down any progression. And so I'm generally going to recommend just taking the standard amount.
And so a question about smoking. So specifically, what is it about smoking that causes macular degeneration or causes it to worsen?
Great question. We don't know specifically what the components are. We look at people who are using, say, e-cigarette products and nicotine containing products instead of general tobacco, and it may be kind of chewing tobacco and stuff like that. And we really see a lot of that impact with any tobacco source. So the recommendation is going to be not to use anything in general. People who have tobacco use aren't necessarily, just because of the tobacco use, more likely to develop macular degeneration, but those who have macular degeneration are generally going to do worse by smoking or having any tobacco.
So it might be safe to say that macular degeneration. So it might be safe to say that that macular degeneration levels in society aren't necessarily dropping because smoking is declining as a percentage of total population use.
Correct. There's a lot of factors that go into it, and probably one of the largest is a genetic component. So an inherited component where, if your mom or grandma or brother, say perhaps, has macular degeneration, that puts you at a more likely category. Age is another big factor, which of course we can't really do a whole lot about.
Right, and as the population continues to age and lives longer, we're likely to see more macular degeneration just because of that factor.
That's correct.
And one more question is, could you describe drusen again?
Yes, so drusen are these deposits beneath the macula and beneath the retina. Drusen comes from a German term for kind of like a gem or potato type thing, and it's mostly made up of lipofuscin, which is kind of like we talked about, one of the light sensing or light pathways of the retina that can accumulate as a byproduct, and there's other kind of byproducts of the light sensing part that are within drusen for macular degeneration. They're a little bit different. We don't truly understand but we'll see drusen in patients who don't even necessarily have macular degeneration. So there's hard and soft drusen, and having hard drusen and having very small drusen is actually a normal part of aging of the eye. It's only when these drusen deposits become very large and kind of a softer form and more prevalent in numbers that's considered more of macular degeneration.
Well, you both doctors did such a tremendous job. It was extremely educating for all of our viewers today. Our time is up. I want to thank both of you again for just terrific presentations and great, very lively question and answer period as well. And I would like to remind everybody again, dailycamera.com/aging. You can visit our virtual expo. Once again, thank you again, and please enjoy your afternoon.